We all know birth is a profound event, right? A new life entering the world. It feels so fundamental, universally understood. But have you ever truly stopped to consider the incredible, intricate dance that happens inside the body to actually make that possible? It's not just, a single moment. It's this symphony of biological processes, a hidden orchestration by the body that remains profoundly complex and, in many ways, still pretty mysterious from a scientific view. Welcome to the deep dive.
Yeah.
Today's mission is to take this stack of detailed medical sources we have on human labor and really unpack its most important facts and insights. We're going beyond just what happens, aiming to explore the why and the how your body and the baby's body too are so intricately involved in this incredible journey. Our goal is to give you a shortcut to being truly well-informed, maybe with some surprising facts and those illuminating aha moments that make complex biology feel, well, accessible and captivating.
Absolutely. We're diving deep into what we're calling the physiological masterpiece of human labor.
Yeah.
And it truly is a masterpiece. It's an incredible biological event, a whole series of precisely coordinated actions by the body, all working together to bring forth new life. So this deep dive, it'll go beyond the common understanding. We'll explore the precise scientific definitions, look at the latest hypotheses on why labor actually starts, which is fascinating in itself. And we'll cover the distinct stages your body moves through, the intricate biomechanical dance the baby performs, and how modern care approaches this, well, ancient process. I think you're going to uncover some truly surprising facts, and yeah, definitely have a few aha moments that might just change how you think about birth.
Okay, fantastic. So let's unpack this right from the start. When we talk about labor, what exactly are we defining? Is it simply, when the baby comes out? Because I think in common conversation, that's often what people mean.
Yeah, that's a common thought, but medically it's more specific. That's actually a crucial distinction and maybe one of the first key insights from our sources. Labor isn't just one single moment, it's a specific process. It's defined as a series of events that take place in the genital organs in an effort to expel the viable products of conception. So that's the fetus, placenta, and the membranes. Out of the womb, through the vagina, into the outer world.
Ah, okay. A process, not just an event. So how is that different from, say, delivery? Are they not the same thing?
Good question. They're related, but not synonymous. Delivery is simply the expulsion or the extraction of a viable fetus. And it can happen without labor. Think about an elective cesarean section, for example. The baby is delivered, but the body didn't go through the labor process to get there. Labor, on the other hand, is specifically characterized by those regular uterine contractions, the progressive thinning, which we call effacement, and the opening or dilatation of the cervix, plus the descent of the baby. Making that distinction is really vital for a clear understanding. It's not just about the baby coming out, but the specific, intense biological work your body does to prepare for and achieve that birth. It's also what helps us understand variations like preterm labor. That's when this whole process kicks off, before 37 completed weeks of gestation.
That makes so much more sense. It really is about the journey and the prep work, with the actual expulsion being like the finale. Okay, so if that's the definition, what makes labor normal versus abnormal from a medical perspective? Are there like strict criteria for that?
Yes, absolutely. There's a clear definition for normal labor, which is medically termed eutosha. It has to tick 5 specific boxes. First, it has to start spontaneously, no induction, and occur at term, so between 37 and 42 weeks of pregnancy. Second, the baby needs to be in a vertex presentation, meaning head first. That's the ideal position. Third, the whole process should unfold without undue prolongation. It shouldn't take an excessively long time. Fourth, it should have a natural termination with minimal aids, meaning it doesn't require significant medical intervention for the baby to actually be born. And fifth, and this is critical, it must occur without any complications for either the mother or the baby.
Okay, 5 specific things. So what happens if one of those isn't met?
Any deviation from those 5 criteria means we're looking at abnormal labor or dystocia. So if the baby isn't head first, or if complications pop up even with a head first presentation, or if the labor just goes on too long, or requires significant intervention, it gets classified as abnormal. And this framework, it's really indispensable for healthcare providers. It guides their decisions, helps them understand potential challenges, and know when to step in.
That's a very clear framework, yeah. Helps classify what's happening. Now, for the big one, the question everyone always asks, probably the most unpredictable part for expectant parents: when will it actually start? Is there a precise answer, or is it truly just a guessing game?
It really is mostly a guessing game, and yeah, that's often a huge source of anxiety or frustration for expectant parents. Our sources are clear. It is very much unpredictable to foretell precisely the exact date of onset of labor. It not only varies massively from case to case, but even in different pregnancies for the same woman.
So that whole due date thing is more of a suggestion then.
Exactly. It raises that important question. Why do we often set expectations so rigidly around a due date when, statistically, the vast majority of births don't happen on that specific day? Our sources highlight some fascinating statistics here that might surprise you. Labor starts approximately on the expected date of delivery in only about 4% of cases.
Only 4%. Wow.
Right, just 4%. 50%, so half of all labors, start within 1 week on either side of that date. And an impressive 80% happen within 2 weeks earlier or 1 week later. Then you have about 10% occurring later at 42 weeks, and another 4% even later at 43 weeks plus.
So basically, all those apps counting down to the exact second of the due date are setting up, what, 96% of people for a surprise?
Pretty much. It really underscores that the body operates on its own unique biological timeline.
Yeah.
And these variations, they are truly the norm, not the exception. It helps manage expectations, maybe.
Definitely good to know. It takes some pressure off that one specific day. Okay, so we know what labor is, what makes it normal, and just how unpredictable its start date can be, but what actually causes it to start? The body isn't just flipping a switch or like setting an alarm clock, is it? It feels like such a monumental decision for the body to make.
It really does. And what's truly fascinating here, maybe even a bit humbling for science, is that despite all our advancements and the sheer universality of birth, the sources state quite clearly the precise mechanism of initiation of human labor is still obscure.
Still obscure, even now.
Even now. This is a key aha moment, I think. Despite everything we know, the ultimate trigger, the thing that says go, it remains largely unknown. It's an active frontier in scientific research. What we do have are leading hypotheses, mostly derived from animal experiments, mind you. And these point towards a complex interplay of endocrine signals, biochemical pathways, and mechanical stretch factors. It acknowledges the profound complexity of the human body, doesn't it? A reminder that there are still fundamental mysteries even in something so common.
That's incredible that something so fundamental is still, well, a mystery in some ways. So it's not one single cause, but potentially a whole host of signals playing a part. Let's dive into these leading hypotheses then. What are the strongest theories on what finally tips the body into labor mode?
Okay, one of the prominent theories involves uterine distension. The basic idea is that the simple physical stretching of the myometrium, that's the muscular wall of the uterus by the growing fetus and all the surrounding amniotic fluid, is thought to act as a trigger. This seems especially relevant in cases like twin pregnancies or polyhydramnios, where there's excessive amniotic fluid leading to much greater stretch.
So the uterus just gets stretched to a certain point and says, okay, that's enough.
Kind of. The thinking is that this stretch increases the number of gap junction proteins. Think of these as tiny communication tunnels connecting the muscle cells. More tunnels mean faster, more coordinated communication, which is essential for effective contractions. The stretch also seems to increase the uterus's sensitivity to oxytocin and other contraction-associated proteins. So yeah, it's just a direct physical signal where sheer size and stretch prompt the uterus to prepare for intense activity.
A sort of fullness signal telling the uterus it's time to gear up. But it's not just the uterus responding on its own, is it? I've heard, and this sounds utterly mind-blowing, that the baby itself might play a role in kicking things off.
Ah, yes. This is where it gets really interesting, and it's often a truly surprising insight for many people. The fetal-placental contribution hypothesis. It describes this remarkable cascade of events where the baby's own system, specifically its hypothalamic-pituitary-adrenal axis, gets activated before labor starts.
Wait, the baby's brain and adrenal glands are involved?
Exactly. Essentially, the baby's brain releases a hormone which stimulates its adrenal glands. These glands then produce more cortisol, and this fetal cortisol then signals the placenta to ramp up its production of estrogen and crucial prostaglandins.
Wow, so the baby's own hormone system is actively participating in initiating its journey out.
Precisely. It's not just a passive passenger waiting for eviction, but an active participant in its own birth timing. It highlights this incredibly complex feedback loop, like a conversation happening between the mother, the baby, and the placenta.
That's a true mind blower, the baby having a say in when it's time. And then you mentioned the hormonal dance earlier. How do hormones orchestrate this whole complex process? They seem central.
Oh, absolutely central. The hormones play a critical, multifaceted role. You can think of them almost like a conductor, preparing and guiding the uterine orchestra for the main performance. First up, we have estrogen. Its role is largely preparatory. It's getting the uterus primed and ready. It increases the release of oxytocin from the mother's pituitary gland. But here's the detail that always gets me. Estrogen promotes the synthesis of myometrial receptors for oxytocin by 100 to 200 folds.
100 to 200 times more receptors.
Yes. Imagine amplifying a signal by that much. That's how precisely your body primes itself, making the uterus incredibly sensitive to even small amounts of oxytocin later on. Estrogen also promotes the synthesis of prostaglandins, increases those crucial gap junctions between muscle cells for better communication, and generally makes the uterine muscle cells more excitable and ready to contract.
Wow, 100 to 200 times. That amplification really tells you something about the body's priority for coordinated contraction when labor truly begins, doesn't it?
It absolutely does. It suggests the body is leaving absolutely nothing to chance when it comes to getting the uterus ready for its monumental task. That level of priming ensures that even subtle levels of oxytocin will have a profound effect when the time is right.
So what about progesterone then? It's often called the hormone that maintains pregnancy. Does its role just disappear?
Well, it's not quite that simple. It's not just an absolute fall in progesterone levels that triggers labor, which is a common misconception. The theory outlined in the sources suggests that while progesterone levels do shift before labor, the critical factor seems to be the alteration in the estrogen to progesterone ratio. This shift in balance is linked with the increased production of prostaglandins. So it's a more nuanced biochemical interaction, a subtle but important distinction in the overall hormonal balance that prepares the body for labor to begin.
Okay, so it's the balance, the ratio, not just one hormone dropping off. And then we have prostaglandins, which you've mentioned a couple of times. They sound incredibly important in this whole process.
They're absolutely crucial. Prostaglandins, or PGs, are like tiny cellular messengers that essentially tell your uterine muscles to ramp up their activity. They are key factors that both initiate and maintain labor contractions. They're produced in various parts of the uterus and the membrane surrounding the baby. Their synthesis gets triggered by several things: the rise in estrogen we just discussed, general stress hormones, the mechanical stretching of the uterus in late pregnancy, and even things like infection or sometimes a vaginal examination.
And they create a feedback loop, you said.
Yes, once the process begins, prostaglandins activate systems that lead to the release of more prostaglandins, creating this positive feedback loop that helps build the momentum and intensity of labor. They play a direct role in causing uterine muscle contraction at the cellular level, and their levels even peak during the birth of the placenta, helping with its expulsion and, very importantly, helping to control postpartum bleeding afterwards. It's a really specific and vital biochemical pathway.
That's a fascinating feedback loop, like a snowball rolling downhill, just gaining speed and power. What about oxytocin? Everyone sort of knows oxytocin as the love hormone and its role in contractions, but how does it fit into the initiation part?
Oxytocin and its receptors are definitely part of the picture. We know there are a large number of oxytocin receptors, especially in the top part of the uterus, the fundus, and their numbers, and crucially their sensitivity, increase dramatically during labor, thanks in part to estrogen. Oxytocin itself is known to stimulate the synthesis and release of those vital prostaglandins we just talked about. And there's also the interesting Ferguson reflex, where stretching the lower genital tract, like during a vaginal exam, or when the membranes rupture, can actually trigger and increase the mother's own oxytocin levels. The baby's oxytocin levels also rise during spontaneous labor.
So it sounds pretty central.
It does, but, and this is an important caveat from the sources, highlighting those remaining scientific unknowns, despite all these known effects and its widespread use to induce or augment labor, its precise role in the natural initiation of human labor is, believe it or not yet fully established. It's clearly vital for maintaining and strengthening contractions once they've started, but its exact role as the initial natural trigger is still being explored.
Wow. So even with something as seemingly obvious and well-known as oxytocin, the full picture of its natural starting role isn't completely clear. Are there any other factors involved, maybe neurological ones, beyond the hormonal and mechanical signals?
Yes, potentially. There can be a neurological factor, which adds yet another layer of complexity to the picture. While we know labor can start perfectly well, even in a denervated uterus, meaning one without direct nerve communication, like after certain surgeries, it can also be influenced through these nerve pathways. For instance, estrogen seems to make certain nerve receptors in the uterus, alpha receptors, more active, which can lead to contractions, while progesterone influences other receptors, beta receptors, that tend to inhibit contractions. We see some evidence suggesting neurological influence when labor sometimes begins shortly after procedures that might irritate the cervix or lower uterus, like stripping the membranes. So it shows that while the uterus can act somewhat autonomously, the nervous system can also chime in, offering another layer of potential control or influence.
Okay, that brings us right down to the bedrock, how the uterus actually contracts. You mentioned the myometrial contractile system earlier. What's actually going on at the microscopic level to make these incredibly powerful contractions happen?
Right, the contractile system of the myometrium. This is the cellular engine room of labor, making those abstract contractions much more concrete. At its very core, uterine muscle cells contain specialized proteins called actin and myosin. For these proteins to interact and cause the muscle cell to shorten, which is a contraction, they need energy, which comes from ATP, adenosine triphosphate, the cell's energy currency. And critically, they need calcium ions, say A++. Think of calcium as the essential key that unlocks the whole contraction process.
So calcium is the trigger at the cell level.
Exactly. When hormones like oxytocin or prostaglandins bind to their receptors on the surface of the uterine muscle cell, they trigger a cascade of events inside the cell that leads to an increase in the concentration of free calcium ions within that cell. This calcium then binds to and activates an enzyme called myosin light chain kinase, or MLCK. This activated enzyme then acts on the myosin protein, allowing it to interact with the actin protein. And that interaction, the sliding of actin and myosin filaments past each other, is what generates the force the muscle contracts.
And relaxation.
Relaxation is essentially the reverse. When the intracellular calcium levels decrease, either pumped out of the cell or shifted back into storage compartments within the cell, the MLCK enzyme becomes inactive, the actin-myosin interaction stops, and the muscle cell relaxes. It's this intricate, tightly regulated dance of calcium ions, enzymes, and proteins, all orchestrated by hormones and other signals, that produces the rhythmic contractions and relaxations of labor. It's a true deep dive into the precise biology of muscle function.
That's an incredible level of detail right down to the cellular level. It really makes the abstract idea of contractions concrete. So if that's the powerful engine driving it all, how does the person actually experiencing it distinguish the real signals from those initial, maybe preparatory ones? What exactly are false pains? Because that seems like a common point of confusion.
It really is, and it's a very practical question. We call them false pains, sometimes known as false labor or spurious labor. And yeah, they're more common in first-time mothers, or prima gravidae. They typically appear maybe 1 to 2 weeks before true labor actually kicks off, or perhaps just a few days prior in women who've had children before the multipare. The thinking is that these pains are likely due to the stretching of the cervix and the lower part of the uterus, which can irritate nearby nerve clusters as things start to shift and prepare.
Okay, so what do they feel like? How are they different?
The key characteristics of false pain are that they tend to be dull, rather than sharp or intense. They're often confined to the lower abdomen and maybe the groin area. They might be associated with a general hardening of the uterus, but, and this is important, they have no other features of true labor. That means they don't cause progressive changes to the cervix, no effacement, no dilatation, and crucially, they're usually relieved by simple pain medication, or sometimes just by changing position or activity. True labor pains won't stop like that.
Right, that makes sense.
So this distinction is very practical for you, the listener, helping to identify what is not true labor, and maybe saving you an unnecessary trip to the hospital or clinic too early.
Okay, so if it's not quite labor, but it's not quite nothing either, what are those other subtle cues the body might give that it's, gearing up? What's this pre-labor stage about?
Pre-labor, or the premonitory stage, is precisely that transition period. It can begin maybe 2-3 weeks before true labor in first-time mothers, or just a few days before in multipare. The features can be a bit inconsistent. They vary from person to person, but they definitely signal that the body is making preparations for the big event down the road.
Like what kind of signals?
Well, one key feature is lightening. This often happens a few weeks before labor starts, especially for first-time mothers. It's when the baby's head sinks down deeper into the true pelvis. This dropping lowers the top of the uterus, the fundus, and that can relieve pressure on the diaphragm. Many women notice a sudden sense of relief from previous shortness of breath. Breathing might actually become easier.
Oh, that sounds like a welcome change.
It often is. And what's fascinating is that lightening is generally considered a good sign medically because it suggests the baby's head is fitting well into the pelvis, which kind of rules out major issues like cephalopelvic disproportion, where the head might struggle to even enter the pelvis. The downside is that this increased downward pressure can sometimes cause more frequent urination or even constipation. But yeah, it's a very tangible example of the body subtly adjusting itself for birth.
Okay, so lightning is one sign. What else happens in pre-labor?
Another sign involves cervical changes. In the few days leading up to labor, the cervix starts to become ripe.
Ripe. Like fruit.
Haha, sort of. A ripe cervix means it's becoming soft, it's thinning out significantly, maybe about 80% effaced, so less than 1.5 centimeters in length, and it might be starting to open just slightly, maybe admitting one finger easily during an exam. The cervical canal becomes more dilatable. And of course, the appearance of those false pains we just discussed can also be a feature of this pre-labor stage. They're all part of the body's quiet preparations, sort of easing the transition into active labor when it comes.
That's really helpful for understanding the lead up, the subtle shifts. But when it's the real thing, how do you know for sure? What are the definitive signs? What should a listener really be looking for to confirm true labor has begun?
Okay, true labor pain is characterized by a very specific set of key features that definitively differentiate it from false labor or pre-labor twinges. There's a kind of checklist. First, you'll experience painful uterine contractions that occur at regular intervals, not random, but rhythmic. Second, the frequency of these contractions increases. Gradually, they start getting closer together over time. Third, their intensity and duration also increase progressively. They get stronger and they last longer. Fourth, true labor is often associated with show. Fifth, and this is crucial for diagnosis, there is progressive effacement and dilatation of the cervix, meaning your cervix is actively thinning and opening, which a healthcare provider can assess. Sixth, there's noticeable descent of the baby's presenting part down into the pelvis. Seventh, there might be the formation of the bag of forewaters. And eighth, crucially, these contractions are not relieved by simple measures like an enema or sedatives. They keep coming, regardless.
Okay, you mentioned show and bag of forewaters. Can you explain those a bit more?
Sure. Show refers to the discharge you might see when true labor begins. It's usually profuse cervical mucus, often mixed with a slight amount of blood. This happens because tiny capillary blood vessels in the cervix can rupture as it starts to stretch and thin out a face. It's basically the expulsion of the cervical mucus plug that was blocking the cervix during pregnancy, now mixed with a bit of blood. It's a clear sign that cervical changes are actively underway. And the bag of forewaters, well, as the lower part of the uterus stretches and the membranes start to detach slightly from it, the amniotic fluid that's below the baby's head can bulge down into the opening cervix during a contraction. This bulging bag of fluid acts like a gentle hydrostatic wedge, helping to dilate the cervix. Seeing this phenomenon, along with those regular progressive contractions and documented cervical changes, is a pretty definitive sign that labor has truly begun. It provides a clear, actionable checklist, emphasizing the progressive, unyielding nature of true labor compared to the more fleeting nature of false labor.
Okay, the signals are clear, the checklist is helpful. Now let's talk about the journey itself. Conventionally, labor is divided into distinct stages, right? How are these stages defined, and what's the main purpose or focus of each one?
That's right. Conventionally, the whole process of labor is divided into three main stages. Plus, there's a crucial fourth observation stage that occurs right after delivery. Each stage has a distinct purpose, a distinct set of physiological events happening, marking this remarkable transformation. The first stage is often called the cervical stage because its entire focus is on preparing the passage for the baby. It officially starts from the onset of those true labor pains we just defined, and it ends when the cervix is fully dilated, meaning it is opened up to 10 centimeters. Its average duration varies quite a bit. It's typically about 12 hours for first-time mothers, the prima gravidae, and roughly half that, maybe 6 hours for those who have given birth before, multipare. The main events happening during this stage are that progressive dilation and effacement of the cervix, and also the full formation of that lower uterine segment we touched on earlier.
Right, 10 centimeters. How does the cervix, which is normally such a tight, closed structure, manage to open up that much? It sounds like an incredible transformation in itself.
It truly is a marvel of biological engineering how it happens. The dilatation of the cervix involves this really complex interplay of factors. First, you have to remember the cervix isn't like the main body of the uterus, which is mostly muscle. The cervix is primarily made of collagen and connective tissue. So its ability to dilate depends heavily on a softening process, or ripening, that happens over the preceding weeks, largely under the influence of hormones like estrogen and relaxin. This softening involves the breakdown of tough collagen fibers and an increase in water content, making the tissue much more pliable and stretchy.
Okay, so it gets softer first. Then what actually makes it open during labor?
Then you have the actual forces responsible for dilatation during the contractions themselves. There are a few key ones. First, uterine contraction and retraction. The powerful muscle fibers in the upper part of the uterus contract and, importantly, they retract, meaning they get progressively shorter and thicker with each contraction. These fibers pull upward on the more passive lower segment and the cervix. This coordinated pulling and pushing effectively opens and thins the cervix from the top down. You can almost picture it like a turtleneck sweater being pulled up and unrolling, merging into the body of the sweater. Second, there's fetal axis pressure. If the baby is in the normal head-first position, strong contractions transmit force down through the baby's spine to its well-fitted head. This direct mechanical pressure from the baby's head helps to physically stretch and open the lower segment and the cervical canal. And third, the bag of membranes, or the bag of forewaters we mentioned. That part of the amniotic sac bulging down below the baby's head acts like a hydrostatic wedge. During contractions, the increasing fluid pressure inside the uterus causes this bag to bulge downwards and exert gentle, even pressure on the cervix, effectively helping to dilate it.
That's incredibly detailed, the different forces all working together. You also mentioned effacement again earlier. Is that the same as dilating, or is it a different part of the process?
It's a distinct but closely related process. Effacement, sometimes called taking up of the cervix, is specifically the process where the cervical tissue thins out and gets drawn upwards, merging into the lower uterine segment. Think of that turtleneck again. Effacement is the process of the neck part unrolling and becoming part of the main garment. Dilatation is the opening getting wider.
Okay, thinning versus opening. Does it happen in a particular order?
It often does, especially for first-time mothers. In prima gravidae, effacement typically precedes significant dilatation, so the cervix often thins out almost completely before it starts to open widely. In contrast, for those who've given birth before, multiperi, both effacement and dilatation tend to occur more simultaneously. And that expulsion of the mucus plug, the show we talked about, is actually a direct result of this effacement process starting.
Got it. And the formation of the lower uterine segment, you said that happens fully in the first stage too. Why is that specific anatomical change so significant?
Right. The lower uterine segment, LS formation, is a really critical dynamic reshaping of the uterus during labor. Before labor starts, the uterus doesn't have such a clear functional division. But during labor, it distinctly separates into an active, contracting, and thickening upper segment, and a relatively passive, stretching, and thinning lower segment. This thinning and widening of the lower segment is crucial. It becomes this soft, cylindrical passageway perfectly designed for the baby to pass through. What's vital for understanding its importance, though, is that this lower segment has poor retractile property compared to the upper segment.
Meaning it doesn't clamp down as well afterwards?
Exactly. It doesn't contract and stay contracted as effectively after the baby is born. And this has significant clinical implications. For instance, most cesarean sections are performed through an incision in this lower segment, precisely because it's thinner and less vascular, making for a safer surgery and better healing. However, if the placenta happens to implant low down in this segment, a condition called placenta previa, or if the segment gets dangerously overstretched in, say, an obstructed labor, there's a much higher risk of complications like severe bleeding or even uterine rupture. So it really demonstrates this remarkable dynamic remodeling of the uterus where specific anatomical zones develop distinct properties that are critical for both the birth process and for understanding potential risks.
Okay, so after all that incredible preparation in the first stage, the cervix fully open, the lower segment formed, it's finally time for the baby to actually move through. This is the second stage. Fetal expulsion, often called the active pushing stage, right?
Precisely. The second stage officially begins with the confirmation of full cervical dilatation, 10 centimeters, and it ends with the complete expulsion of the fetus from the birth canal. Its average duration, again, varies typically around 2 hours for first-time mothers, but often a much brisker 30 minutes or so for those who've given birth before. This stage itself actually has two distinct phases. First, there's the propulsive, or sometimes called the passive phase. This is from full dilatation until the baby's head descends down to touch the pelvic floor. Then comes the expulsive, or active phase. This is distinguished by the mother experiencing that strong, often irresistible reflex urge to bear down and actively push with her contractions until the baby is delivered.
So the pushing isn't necessarily right from the start of the second stage?
Not always, especially in first labors. The urge often builds as the head descends lower. The delivery of the fetus itself is accomplished by this powerful downward thrust generated by the uterine contractions, which is then strongly supplemented by the mother's voluntary contraction of her abdominal muscles, those bearing down efforts. These combined forces work to push the baby down against the natural resistance offered by the birth canal tissues. And crucially, the uterus's power of retraction, a progressive shortening and thickening of the upper segment muscles, effectively counterbalances the elastic recoil of the birth canal tissues, ensuring that the baby makes continuous forward progress with each push, rather than slipping back significantly. So yes, this is definitely the active pushing stage, where the mother's conscious efforts combine synergistically with her body's powerful involuntary uterine forces to bring forth the new life.
And then, after the baby finally arrives, the work still isn't quite done, is it? There's still the afterbirth to deal with, the third stage, placental delivery. What exactly happens here, and how does the body manage to expel the placenta and control bleeding so effectively? That seems critical.
It is absolutely critical. The third stage of labor is surprisingly rapid compared to the others, but it's incredibly high stakes. It begins immediately after the expulsion of the fetus and ends with the complete expulsion of the placenta and the membranes, collectively known as the afterbirths. Its average duration is typically about 15 minutes, although this is often significantly reduced, maybe down to 5 minutes or so, with what we call active management, which we can discuss later. The key event driving this stage is placental separation. What happens is, immediately following the birth of the baby, the uterus undergoes marked retraction. It dramatically shrinks in size. This significantly reduces the surface area of the site where the placenta was attached, maybe shrinking it down to about half its original size.
And the placenta can't shrink with it.
Exactly. Since the placenta itself is relatively inelastic, it simply cannot keep pace with such rapid uterine shrinkage. This causes the placenta to essentially buckle away from the uterine wall. This buckling creates a powerful shearing force, which effectively peels the placenta off the uterine wall, usually through the deep, spongy layer of the decidua basalis. This separation can happen in a couple of ways. Central separation, where it starts detaching from the middle and blood collects behind it, or marginal separation, where it starts peeling off from the edge, which is actually found more frequently.
Okay, so it peels off. How does it get out?
Once it's separated, the expulsion of placenta occurs. It's usually forced down into the now passive lower uterine segment or the upper vagina by further uterine contractions. From there, it's expelled out of the body either by the mother's voluntary bearing down efforts or sometimes with gentle medical assistance.
And the bleeding control, that seems like the most dangerous part.
It is, and the body has an incredibly elegant and vital solution for this: the mechanism of bleeding control, or hemostasis. After the placenta separates, you have essentially innumerable torn blood vessels left open on the uterine wall, which could lead to massive hemorrhage. The principal mechanism the body uses to stop this bleeding is the uterus's complete retraction. Those powerful uterine muscle fibers, which run in crisscrossing layers, permanently shorten and clamp down hard on the blood vessels that weave through them. This action is aptly called the living ligature.
Living ligature. Wow.
Isn't it? It's like the uterus acts as its own internal living tourniquet, effectively strangulating the bleeding vessels. Additionally, blood clots naturally form at the torn vessel openings, helped by the fact that pregnancy is a hypercoagulable state, and the simple apposition or pressing together of the uterine walls after the placenta is out also helps to minimize blood loss. So yes, this stage, though often the shortest, is definitely high stakes. And the elegant efficiency of the body's living ligature mechanism is a truly prime example of brilliant biological design and resilience, ensuring the mother's safety after birth.
That's truly amazing, the living ligature. It paints such a vivid picture. And then you mentioned there's even a fourth stage. What on earth is that for, and why is it important if the baby and the placenta are already out?
Yes. The fourth stage is essentially the crucial immediate recovery and observation period. It's generally defined as lasting for at least 1 hour after the expulsion of the afterbirths, the placenta and membranes. During this critical first hour, the mother's vital signs, her pulse, blood pressure, are closely monitored. The tone of her uterus is repeatedly checked by feeling her abdomen, ensuring it remains firm and well retracted, and any vaginal bleeding is very carefully watched and assessed. The baby is also usually thoroughly examined during this time as well.
So it's really about making sure everything settles down properly.
Exactly. The purpose is paramount to ensure that both the mother and the baby are stable and well, and crucially, to detect any immediate post-delivery complications. The biggest concern here is often a delayed postpartum hemorrhage, which can happen if the uterus doesn't stay firmly contracted. This stage highlights that the process of care doesn't just stop the moment the baby is born. This immediate postpartum period is absolutely critical for preventing potentially life-threatening complications.
We've gone deep into the maternal processes, all the incredible transformations happening in the uterus and the birth canal. But what about the baby's side of things? It's not just being passively pushed out like toothpaste from a tube, is it? There's a whole series of precise movements it has to perform during birth. That's the mechanism of normal labor, isn't it?
Absolutely, you're spot on. The mechanism of normal labor refers to precisely that, the series of movements that occur on the head in the process of adaptation during its journey through the pelvis. It's often described as a beautifully choreographed dance, an intricate interplay between the baby, the passenger, and the mother's changing anatomy, the passage. While we primarily focus on the movements of the baby's head, because it's the largest and least compressible part, the entire fetal trunk is actually involved too, either participating in or sometimes initiating these movements. In a normal labor, the baby's head most commonly enters the pelvic brim oriented sideways or slightly obliquely to fit through the widest diameter of the pelvic inlet. And while we tend to describe these principal movements sequentially for clarity, it's important to remember that in reality, many of them happen smoothly and simultaneously.
Okay, a dance of adaptation. So what are these principal movements? What's the choreography the baby follows to navigate the twists and turns of the birth canal?
All right, let's break down the steps of this dance, keeping in mind their smooth, integrated nature. First, we have engagement. This is defined as the moment when the widest diameter of the baby's presenting part, usually the head's biparietal diameter, successfully passes through the plane of the pelvic inlet, the bony entrance to the true pelvis. Often the head doesn't enter perfectly straight on. It might be tilted slightly to one side, with one parietal bone, side of the head, leading lower than the other. This slight tilting is called asynclitism.
Is that a problem?
Actually, no, mild asynclitism is often beneficial. It allows the baby's head to present a slightly smaller effective diameter as it negotiates the brim, making it easier to navigate that tight space. It's almost like turning your shoulder slightly to fit through a narrow doorway. So a little bit is normal and helpful. Marked or persistent asynclitism, however, could indicate a potential fit issue.
Okay, so engagement is getting into the pelvis. What's next?
Next is descent. Provided there's no obstruction preventing it, descent is a continuous process throughout labor. It might be slow in the first stage, but it becomes much more pronounced and obvious during the second stage, ultimately completing only when the baby is fully expelled. Descent is driven primarily by the force of uterine contractions, supplemented by the mother's pushing efforts in the second stage, and also helped by the straightening of the baby's body once the membranes rupture.
Makes sense, moving downwards. Then you mentioned flexion.
Yes, flexion. While the baby's head is usually somewhat flexed, chin towards chest, from the start due to the natural muscle tone and the shape of the uterus, full flexion is typically achieved as the descending head meets resistance from the pelvic floor muscles or the cervix itself. The baby tucks its chin tightly down onto its chest. This movement is absolutely critical for descent because it effectively reduces the presenting diameter of the head, substituting the smaller suboccipitobregmatic diameter, about 9.5 centimeters, for the larger occipitofrontal diameter, about 11.5 centimeters. It ensures the smallest possible circumference of the head presents to navigate the narrowest parts of the pelvis. Think of it like trying to squeeze through a small opening. You automatically tuck your chin down, right? Same principle.
A clever natural maneuver. What happens after flexion?
Following flexion comes internal rotation. This movement is described in our sources as being of great importance because without it, further descent through the mid-pelvis would usually be impossible. During internal rotation, the baby's head rotates, usually from a sideways, transverse, or oblique position, so that the back of the head, the occiput, moves towards the front, typically coming to lie directly underneath the mother's pubic bone, the symphysis pubis.
What makes it rotate like that?
It's guided primarily by the shape of the bony pelvis and the slope of the pelvic floor muscles, particularly the levator ani. These muscles form a kind of natural gutter that encourages the presenting part, usually the occiput, to rotate forward towards the midline with each contraction and descent. It's essentially the internal corkscrew movement, aligning the longest diameter of the baby's head with the longest available diameter of the pelvic outlet, which is the anteroposterior diameter, front to back. This rotation of the head also causes an inevitable twisting, or torsion of the neck. The baby's neck twists relative to its shoulders, which are still entering the pelvis in a different orientation. The shoulders also rotate simultaneously, but usually to a lesser degree, which helps reduce the amount of strain on the neck.
Okay, so it turns to face downwards, more or less.
Yeah.
Then what?
Then comes crowning. After internal rotation is complete, further descent occurs until the subocciput, the area just below the back of the baby's head, comes to lie snugly underneath the pubic arch. At this crucial stage, the maximum diameter of the head, the biparietal diameter, significantly stretches the vulval outlet, the vaginal opening. And the defining feature of crowning is that there is no recession of the head back inside between contractions. Once it reaches this point, it stays visible. It signals that the birth of the head is imminent.
The point of no return, almost. What's the next movement?
The next movement is extension. The actual delivery of the head takes place by a movement of extension. As the flexed head continues to be pushed downwards by contractions but meets the resistance of the pelvic floor pushing upwards and forwards, the net result is that the head pivots around the pubic bone and extends. Basically, the head untucks from the chest and tilts backward. As it extends, the vertex, top of the head, then the brow, and finally the face emerge successively through the stretched vaginal opening, sweeping over the perineum.
So the head is born. What happens right after that?
Immediately after the head is born, you'll see restitution. This is a visible passive movement of the head. It's essentially the untwisting of the neck from the torsion it sustained during internal rotation. The head spontaneously rotates back about 45 degrees, 1/8 of a circle, in the direction opposite to the internal rotation, realigning itself with the baby's shoulders, which are still inside the pelvis. The back of the head will now point towards the mother's thigh on the side it originally started on.
Ah, it untwists itself. Then there's another rotation.
Yes, following restitution is external rotation. This is another visible rotation of the head, but this time it's caused by the internal rotation of the baby's shoulders as they maneuver to fit through the pelvis, usually aligning themselves in the anteroposterior diameter front to back of the pelvic outlet. As the shoulders rotate internally, they carry the head along with them externally, causing it to rotate another 45 degrees, 1/8 of a circle, in the same direction as restitution. So now the baby's head is facing sideways relative to the mother.
Okay, head and shoulders aligned. How does the rest come out?
Finally, the birth of shoulders and trunk. After the shoulders are aligned in that anteroposterior diameter, the anterior front shoulder usually emerges first, slipping out from under the symphysis pubis. Then, by a movement of lateral flexion of the baby's spine bending sideways, the posterior back shoulder sweeps over the perineum. Once the shoulders are born, the rest of the trunk usually follows quite easily and quickly, often with the same lateral flexion movement. This entire sequence, these cardinal movements, represent a truly remarkable feat of biomechanical adaptation, a testament to the baby's active role in navigating the complex passage of birth.
That's an incredible sequence of precise maneuvers. It really drives home that idea of a dance of adaptation. And for the mother's body, what specific transformations does the birth canal itself undergo to actually accommodate this intricate journey? It must stretch enormously.
Oh, enormously. The anatomy of labor truly showcases the profound transformations the birth canal undergoes. As labor advances and the baby descends, the body of the uterus, the now fully dilated cervix, and the vagina essentially merge to form one continuous, uniformly curved soft passageway. As the baby's head descends through this passage, it dramatically displaces the surrounding maternal organs. Anterior structures like the urethra and the bladder get pushed upward and forward out of the pelvis and into the abdomen, while posterior structures like the rectum, the anal canal, the perineum itself, and the anacosseal raphe, the tissue between the anus and the tailbone, get displaced downward and backward. One source vividly describes it as if the head is passing through a swing door, pushing everything out of its way.
Wow. What are some of the specific changes? How much does it stretch?
Some specific changes are quite remarkable. The bladder, which is normally a pelvic organ, effectively becomes an abdominal organ during the second stage of labor. The perineum, the area between the vagina and anus, which is typically about 4 centimeters thick, becomes stretched into this incredibly thin, almost membranous structure, sometimes less than 1 centimeter thick just before the baby crowns. The anus itself, normally a closed sphincter, often dilates open by 2 to 3 centimeters due to the intense pressure. And the posterior wall of the birth canal, from the cervix down to the outlet, lengthens significantly due to the stretching of all the soft tissues and the backward displacement of the sacrum and coccyx. Can become about 23 centimeters long, while the anterior wall remains much shorter, around 4 centimeters. This visually impactful description really helps you understand the profound physical changes, the incredible plasticity and adaptability the maternal body undergoes to accommodate birth. It's truly an awe-inspiring feat of nature.
That's an astonishing amount of reshaping and stretching. Just incredible. Okay, so given all these intricate physiological processes happening in the mother and the baby's complex maneuvers, how do healthcare providers actually monitor and manage labor in practice to ensure the best possible outcome? What does the clinical course of the first stage of labor look like from their perspective? What are they watching for?
Right. From the clinical perspective, the first symptom they usually observe is the onset of those intermittent, painful uterine contractions, often followed by the expulsion of that blood-stained mucus, the show. It's important to note that any bleeding beyond just a few drops mixed with mucus is considered abnormal and needs investigation. In terms of pain, the contractions are typically felt more anteriorly, with a simultaneous hardening of the uterus that the provider can feel. Initially, the pains might be mild and infrequent, but they gradually get closer together, stronger, and last longer. In the late first stage, good contractions might be coming every 3 to 5 minutes, lasting about 45 seconds, and making the uterine wall feel very firm and unable to be indented during the peak. The pain itself comes from a few sources: lack of oxygen in the uterine muscle during intense contraction, myometrial hypoxia, stretching of the peritoneum over the uterus, stretching of the cervix, and some pressure on nerve ganglia.
And they're tracking the cervical changes directly.
Yes, the dilatation and effacement of the cervix are key markers of progress. These progressive anatomical changes are meticulously assessed and recorded after each vaginal examination. Cervical dilatation is measured in centimeters, with the goal being 10 centimeters for full dilatation. Effacement, the thinning, is usually expressed as a percentage, with 100% effacement meaning the cervix is paper thin, less than 0.25 centimeters thick. A really critical tool used for monitoring this progress is the partograph. This is essentially a specialized graph, a composite record that plots the cervical dilatation and the descent of the baby's head against the duration of labor in hours. It also includes space to record vital fetal and maternal conditions, all on a single sheet.
Why is the partograph so important?
It's invaluable because it provides an objective visual representation of how the labor is progressing over time. It allows caregivers to easily identify if things are proceeding normally or if there's a delay or deviation from the expected pattern, like labor slowing down or stopping. This helps ensure timely intervention if it's needed. It really turns a somewhat subjective experience into an objective, plotted journey. They also monitor the status of the membranes, whether the amniotic sac is intact or has ruptured. Rupture usually causes a gush or trickle of amniotic fluid and can often accelerate contractions. Generally, the maternal system remains largely unaffected in normal labor, although transient fatigue is common. Pulse rate and blood pressure might increase slightly during contractions, but should return to baseline levels between them. Temperature typically remains unchanged. And for the fetal effect, as long as the membranes are intact and the placenta is functioning well, there's usually hardly any adverse effect on the baby in the first stage. However, during contractions, the fetal heart rate, FHR, might slow down temporarily by 10-20 beats per minute, but crucially, it should quickly recover back to its normal baseline rate, usually between 110 and 160 BPM, as soon as the contraction ends. This careful monitoring ensures any subtle signs of fetal distress are detected early.
So the partograph is key for tracking progress, turning that subjective experience into something objective. How is this meticulous monitoring and actual management carried out during the first stage of labor? What's the practical approach for care providers on the ground?
The guiding principles for managing the first stage are really twofold. First, it's about allowing for a natural birth process with what's called watchful expectancy. This means generally non-interference unless there's a clear indication it's necessary. Second, it involves careful and continuous monitoring of the progress of labor, the mother's condition, and the baby's well-being, precisely to detect any complications or deviations from normal early on. In terms of general care, providing constant supervision, encouragement, emotional support, and reassurance is absolutely crucial to help maintain the patient's morale and coping ability. Having a chosen companion present for continuous emotional support is strongly recommended in the sources, as studies show it can actually reduce the need for pain relief medication and even decrease the rate of operative delivery. Maintaining privacy and dignity is also paramount.
What about things like movement or eating?
Good question. Positioning is important. In early labor, women are often encouraged to be mobile and change positions as they feel comfortable, avoiding lying flat on their back for prolonged periods, as that can sometimes compress major blood vessels, aortic caval compression. Ambulation, walking around, if the membranes are still intact, can sometimes help reduce the duration of labor and improve comfort levels. Regarding diet, food is generally withheld once active labor begins. This is because stomach emptying slows down significantly during labor, and there is a potential risk of aspiration if general anesthesia were to become unexpectedly necessary. However, clear fluids like water, ice chips, or sometimes juice are usually encouraged in early labor to maintain hydration. Bladder care is also vital. Women are encouraged to empty their bladder regularly, as a full bladder can actually inhibit uterine contractions and increase the risk of infection. Catheterization might be done if needed.
And pain relief.
Pain relief options are usually discussed. Commonly used medications include things like pethidine, an opioid, often given intramuscularly during the active phase. However, the timing is crucial because if given too close to the time of delivery, within about 2 hours, it can cause respiratory depression in the newborn. Anti-nausea medication might also be given. Other methods like epidural anesthesia are options too, of course. Assessment of progress and partograph recording is meticulous, as we discussed. Maternal vitals like pulse, BP, and temperature are checked regularly, maybe every 30 minutes to an hour for pulse BP, a couple of hours for temp. Uterine contractions are assessed for frequency, intensity, and duration, and charted. Critically, fetal well-being is monitored primarily by assessing the fetal heart rate, FHR. This is typically done every 30 minutes during the first stage, or more frequently, like every 15 minutes, in the second stage or after the membranes have ruptured. The rate is counted for a full minute, ideally immediately after a contraction ends to check for recovery. The normal baseline FHR is considered to be between 110 and 160 beats per minute. It's important to distinguish it from the mother's pulse. Continuous electronic fetal monitoring, EFM, is often used for pregnancies considered high risk. Vaginal examinations are performed, but usually minimally to reduce the risk of infection, especially after the membranes have ruptured. Maybe every 3 to 4 hours is typical in a normal labor, or more often if there's a specific reason. These exams assess cervical dilatation and effacement, confirm the baby's position and station, how low the head is, check the status of the membranes and the color of the amniotic fluid, and assess for things like caput, swelling on the baby's scalp, or molding, overlapping of skull bones. Throughout all this, caregivers are also watching for any signs of maternal distress, like a persistently rapid pulse, signs of dehydration, fever, or changes in behavior, which could indicate a developing problem.
That's a huge amount of active, careful monitoring to ensure everything is progressing safely and normally. Okay, so once the cervix finally reaches that magic 10 centimeters, we enter the second stage of labor. How does the clinical management change then as the baby is actively moving down and towards birth?
Right, the transition into the second stage is usually quite evident. You see an increase in the intensity and frequency of contractions. The mother often develops that clear, involuntary bearing down effort or urge to push, sometimes feeling like she needs to have a bowel movement. And of course, a vaginal exam confirms complete cervical dilatation. The principles of management in the second stage are very clear. First, to assist in the natural expulsion of the fetus, guiding it slowly and steadily. And second, and critically, to prevent injuries to the mother's perineum. General measures include ensuring the patient is usually in bed at this point, under constant supervision. Fetal heart rate monitoring becomes more frequent, typically every 5 minutes or after each contraction. Inhalation analgesics like gas and air, nitrous oxide, and oxygen might be offered for pain relief during contractions. A vaginal examination is usually done at the very start of the second stage to confirm full dilatation, recheck the baby's exact position and station, and importantly, to rule out any accidental cord prolapse now that the cervix is open. Preparation for delivery involves getting everything ready. The woman is usually positioned in a way that's comfortable and effective for pushing. Common options include a semi-sitting position, lying on her side, or a dorsal position with a slight tilt to the left to avoid that aortocaval compression. The accoucheur, the person assisting the birth, prepares by scrubbing up and putting on sterile gown, mask, and gloves. Strict aseptic procedures are followed the 3 C's: clean hands, clean delivery surface, and clean cutting and ligaturing of the umbilical cord. The external genital area is cleaned, and sterile drapes are placed. The bladder is usually catheterized if it feels full, as a full bladder can obstruct descent.
Okay, everything's prepped. What about the actual delivery part, the hands-on guidance?
Now, the conduction of delivery, this is where the art and science of midwifery or obstetrics really combine. For the delivery of the head, the main goals are to maintain the baby's head in a flexed, chin-tucked position as it descends, to prevent it from extending, looking up, too early, and crucially, to regulate its slow, controlled escape from the vagina to minimize perineal trauma. The mother is encouraged to bear down. to push effectively during her contractions. As the baby's scalp becomes visible at the vaginal opening and begins to stretch the perineum, maybe visible for about 5 centimeters, the care provider often uses techniques to help maintain flexion and control the speed of delivery. This might involve gentle pressure on the baby's occiput, back of the head, with one hand while supporting the perineum with the other. The aim is to ensure the smallest diameter of the head distends the vulval outlet, which minimizes stretching.
An episiotomy. Is that always done?
No, episiotomy, that surgical cut to enlarge the vaginal opening, is performed selectively, not routinely anymore in most places. It's usually considered only when the perineum is fully stretched and appears highly likely to tear badly, particularly in first-time mothers, or if there's a need to expedite delivery for fetal reasons. If done, it's performed under local anesthesia just before crowning. The degree of perineal bulging is often a better indicator for needing one than just how much scalp is visible. The actual slow delivery of the head is ideally regulated to happen between contractions, when the pushing force is less intense. A specific technique called the Ritchins maneuver might be used. This involves applying upward pressure on the baby's chin through the perineum while simultaneously controlling the occiput with the other hand, allowing the forehead, nose, mouth, and chin to emerge slowly and controlled by extension.
Okay, the head is born. What happens immediately after that?
Right after the head is delivered, the first priority is the airway. Mucus and blood are immediately wiped or gently suctioned from the baby's mouth and pharynx to prevent aspiration when the baby takes its first breaths. The eyelids might be gently wiped. Then the care provider quickly palpates the baby's neck to check if the umbilical cord is looped around it. This happens in about 20–25% of births. If a loop is present and loose, it's simply slipped over the baby's head or shoulders. If it's tight and can't be slipped off, it's usually clamped in 2 places and cut carefully between the clamps to free the baby before the shoulders are born. The focus on prevention of perineal laceration continues throughout. Controlled head delivery, avoiding premature or forceful extension, delivering the head slowly between contractions, and performing a timely episiotomy only when indicated are all key strategies.
How are the shoulders delivered? Does that happen right away?
Note, the delivery of the shoulders is usually not rushed. The attendant typically waits for the next uterine contraction and for the baby's head to complete those movements of restitution and external rotation, which signals that the shoulders inside have rotated to align with the anteroposterior front-to-back diameter of the mother's pelvic outlet. Once aligned, the anterior front shoulder is usually born first, slipping out from under the pubic bone, often with gentle downward guidance of the baby's head. Then, by gently lifting the head upwards, the posterior back shoulder is delivered, sweeping over the perineum. All traction applied should be gentle and aligned with the baby's spine to avoid injury to the brachial plexus nerves in the neck or shoulder, or fracturing the clavicle. Once the shoulders are born, the delivery of the trunk usually follows quite easily and smoothly, often assisted by gently guiding the baby's body out with a lateral flexion movement.
That's an amazing level of precision and careful intervention when needed. What happens right after the baby is fully delivered then? What's the immediate care of the newborn involve?
As soon as the baby is fully born, the priorities shift immediately to ensuring its smooth transition to life outside the womb. The baby is usually placed on a clean, dry, warm surface, often a pre-warmed tray or towel, maybe on the mother's abdomen or chest for skin-to-skin contact if conditions allow. The head might be positioned slightly downward initially, about 15 degrees, just to facilitate the drainage of any remaining mucus or fluid from the airway by gravity. Some protocols also suggest keeping the baby slightly lower than the level of the uterus initially to potentially encourage some blood transfer from the placenta before the cord is clamped. The airway is the top priority. Any remaining mucus or amniotic fluid in the oropharynx, mouth and throat, is cleared promptly by gentle wiping or suction. Then the APGAR rating is assessed and recorded. This is a quick scoring system done at 1 minute and again at 5 minutes after birth to evaluate the newborn's vital signs, heart rate, respiratory effort, muscle tone, reflex irritability, and color, giving a score out of 10 that indicates the baby's overall condition and need for any resuscitation.
And clamping the cord, when does that happen?
Clamping and ligature of the cord is the next step. The umbilical cord is typically clamped with 2 clamps, placed a few centimeters away from the baby's umbilicus, belly button, and then cut cleanly between the clamps. Sterile ligatures, size, or a plastic clamp are then applied closer to the baby. The timing of cord clamping is actually quite important and a topic of much discussion. Delaying clamping for maybe 2–3 minutes or until the cord stops pulsating allows for the transfer of a significant amount of extra blood, around 80–400 ml, from the placenta to the baby. This placental transfusion is generally considered beneficial for healthy, mature infants, potentially improving iron stores. However, for preterm or low birth weight babies, this extra volume could potentially contribute to issues like hypervolemia, too much blood volume, or hyperbilirubinemia, jaundice. Early clamping within the first minute is usually done in specific situations, like for babies born to mothers with Rh incompatibility to prevent transfer of antibodies, for babies needing immediate resuscitation or sometimes in cases of maternal diabetes. Most guidelines now recommend delayed clamping for healthy term infants, usually after the airway is clear and the baby is stable, often around 1 to 2 minutes after birth.
Okay, cord clamped. What else happens right away?
After the cord is dealt with, a quick visual check is made for any obvious gross abnormalities. The baby is then thoroughly dried and wrapped in a dry, warm towel or blanket to prevent heat loss, which newborns are very prone to. Identification bands are usually placed on the baby's wrist or ankle and also on the mother. Once the management of the third stage of labor is complete and the baby is stable, the baby is typically given to the mother for that important skin-to-skin contact and early breastfeeding initiation, or passed to a nurse for further observation if needed.
It's clear that vigilance extends right to the newborn from the very first second. Then comes the third stage management itself, which you mentioned is absolutely crucial for preventing complications like hemorrhage. How is this stage managed to ensure the mother's safety? That seems paramount.
It is paramount. The third stage is indeed considered the most crucial stage from the perspective of preventing immediate life-threatening complications for the mother, primarily postpartum hemorrhage, PPH. Even if the first and second stages were completely uneventful, things can go wrong very quickly in the third stage. So the principles here are strict vigilance and adherence to established management guidelines. There are generally two main approaches described: active management, which is now the preferred and recommended method globally, and expectant management, the more traditional approach.
What's involved in active management? Why is it preferred?
Active management of third stage of labor, AMTSL, is preferred because evidence shows it significantly reduces the risk of PPH. Its core principle is to proactively excite powerful uterine contractions within 1 minute of the baby's delivery by giving the mother a parenteral, usually intramuscular, oxytocic drug, typically oxytocin. 10 units IM is the preferred agent. The idea is that this injection not only facilitates earlier separation of the placenta from the uterine wall, but also, crucially, ensures effective uterine contractions after the placenta has separated, clamping down those blood vessels, reinforcing that living ligature effect.
What are the benefits and any downsides?
The advantages of AMTSL are quite significant based on large studies. It minimizes blood loss during the third stage by approximately 1/5 compared to expectant management. It shortens the duration of the third stage by about half, and consequently, it reduces the incidence of maternal anemia postpartum. Are there downsides? Well, some studies suggest a slightly increased incidence of retained placenta, where the placenta doesn't detach easily, requiring manual removal, maybe around 1–2%. And there's that critical danger we mentioned earlier: the risk associated with accidental administration in an undiagnosed twin pregnancy before the second twin is born. The resulting intense tetanic uterine contractions could compromise the second baby. So if twins are suspected or known, the oxytocic is typically withheld until after the second baby's delivery.
Okay, so the injection is given. What happens next in AMTSL?
After the oxytocic injection is given, ideally within 1 minute of the baby's birth, the placenta is expected to separate and descend fairly quickly. If it doesn't deliver spontaneously within a few minutes, then controlled cord traction, CCT, is performed. CCT is a specific technique where the care provider places one hand on the mother's lower abdomen just above the pubic bone to support and brace the uterus. This is called countertraction, preventing uterine inversion, while the other hand applies steady, gentle downward and slightly backward tension on the umbilical cord. This is only done when the uterus is felt to be well contracted, hard from the oxytocic. It should feel like gentle guidance, not forceful pulling. If the placenta doesn't descend with 1 or 2 attempts, the provider waits and tries again shortly. If it still fails after a reasonable period, example 10 and 15 minutes, then manual removal of the placenta under anesthesia is usually necessary. An alternative oxytocic like misoprostol, oral or rectal, might be used in settings where injectables aren't feasible, like some home births assisted by community health workers.
What happens right after the placenta is out?
As soon as the placenta is delivered, post-expulsion care involves gently massaging the uterine fundus through the abdomen to ensure it becomes and remains firm and hard, which helps expel any retained blood clots. Often another dose of oxytocin, maybe via Zyvi infusion, or sometimes methergine, another uterotonic drug, though oxytocin is generally preferred due to fewer side effects, is given to help maintain that crucial uterine tone. Then comes the absolutely vital step: examination of the placenta, membranes, and cord. The delivered placenta is meticulously inspected on both its maternal, rough, and fetal shiny surfaces to ensure it is complete, checking that all the cotyledons lobes are present and none have been torn off and left inside the uterus. The membranes, amnion and chorion, are also held up and checked for completeness and for any abnormal blood vessels running through them, which might indicate a retained sexcentriate accessory lobe. The cut end of the umbilical cord is also examined to count the vessels, normally 2 arteries and 1 vein.
Why is checking for completeness so critical?
Because any missing pieces of placenta or significant portions of membrane left behind in the uterus can prevent the uterus from contracting down properly and can lead to delayed postpartum hemorrhage or infection later on. If there's any suspicion of retained products, an urgent manual exploration of the uterus is required. Finally, after the placenta is out and examined, the mother's vulva, vagina, and perineum are carefully inspected for any tears or injuries sustained during birth, and any necessary repairs, including suturing the episiotomy if one was performed, are carried out. The area is then cleaned and a sterile pad is applied.
Okay, that covers active management. What about the traditional expectant management? How does that differ?
Expectant management is the more traditional hands-off approach. The principle here is to allow placental separation and descent to occur spontaneously, driven by natural uterine contractions, with minimal intervention or assistance for the actual expulsion. It involves constant watchful waiting, keeping an eye out for clinical signs that the placenta has separated, like a small gush of blood, lengthening of the cord, the uterus becoming firmer and rising in the abdomen. The caregiver often keeps a hand resting lightly on the uterine fundus just to monitor its activity and tone, and to detect any rare early signs of uterine inversion. Some proponents advocate a strict no-touch or hands-off policy regarding massaging the fundus before the placenta separates, believing it might interfere with the natural process. The patient is typically expected to expel the placenta on her own, perhaps aided by gravity or by bearing down when she feels a contraction, usually within about 20-30 minutes. If it doesn't deliver spontaneously and there's no excessive bleeding, assisted methods might be used after a period of waiting, or manual removal might eventually be necessary. It relies much more on patience and natural processes.
It's clear why active management is generally preferred for reducing risk. That brings us back to the fourth stage of labor, the observation period. You mentioned it's crucial, but what exactly are healthcare providers looking for during this final hour or so?
Right, the fourth stage of labor is that critical, immediate postpartum observation period, lasting for at least 1 hour after the delivery of the baby, placenta, and membranes are all complete. During this vital time, the mother's pulse and blood pressure are monitored frequently, maybe every 15 minutes initially. The uterine tone is assessed repeatedly by palpating the fundus through the abdomen. The goal is to ensure it remains well retracted, firm, and hard like a grapefruit, not becoming soft or boggy. Any abnormal vaginal bleeding is meticulously monitored, checking the perineal pads regularly for the amount and character of blood loss. The baby is also usually thoroughly examined during this period as well.
What's the main goal of this intense observation?
The primary purpose is vigilance, to ensure that both the mother and the baby are transitioning well and remain stable, and critically, to allow for the immediate detection and response to any unexpected early complications. The biggest concern, as we've said, is often a delayed postpartum hemorrhage, which can occur if the uterus fails to maintain its contraction, a condition called uterine atony. Other issues like reactions to anesthesia or developing high blood pressure could also be picked up. Only when the caregivers are fully satisfied that the mother's general condition is good, her vital signs are stable and within normal limits, her uterus is well retracted and firm, and there is no abnormal or excessive vaginal bleeding, is she typically considered stable enough to be transferred from the delivery area to the postpartum ward. This final stage really underscores the continuum of care, emphasizing that safe birth is a holistic process that extends well beyond the moment of delivery itself, requiring crucial post-delivery vigilance.
We've taken this truly incredible deep dive into the how and the why of labor, the physiology, the mechanics, but the where of birth is also a really important consideration in the bigger picture, isn't it? The place of delivery and the surrounding environment of care. How do the sources address that?
Indeed, the where is a critical factor. While the sources state that about 85% of deliveries are likely to be uncomplicated, unforeseen complications can arise rapidly and unexpectedly in the remaining cases, requiring urgent, skilled medical management that might not be available outside a hospital setting. This is why, from a purely safety-focused medical perspective, the ideal recommendation is often for all women to have an institutional delivery in a hospital or dedicated birth center where access to emergency obstetric care, anesthesia, blood transfusion, and neonatal support is immediately available if needed.
So the push is towards hospital births for safety.
From a public health standpoint, yes. Global goals, like the Sustainable Development Goals, SDGs, aim to achieve 100% of deliveries being attended by skilled birth attendants, SBAs, doctors, midwives, or nurses, with the appropriate training specifically to significantly reduce preventable maternal and perinatal mortality rates by 2030. Institutional delivery makes access to SBAs much more likely. However, we see contrasting approaches and trends globally. In many developed countries, there's actually a growing demand among women with low-risk pregnancies for home delivery, often emphasizing minimal intervention and seeking a more natural birth experience in a familiar environment, usually attended by community-based midwives with established protocols for transfer if needed. Conversely, in many underprivileged sectors or resource-poor settings, home delivery isn't necessarily a choice, but a necessity, often attended by traditional birth attendants with variable training or even relatives, simply due to lack of access or affordability of institutional care. Referral hospitals in these areas often end up managing the complicated or neglected cases transferred in late.
Is there anything to bridge that gap for emergencies outside hospitals?
One important safety net described in some systems is the flying squad. This is essentially a mobile emergency obstetric team, typically consisting of an experienced obstetrician, an anesthetist, and specialized nursing staff equipped with portable resuscitation gear. They can be rapidly dispatched to emergencies occurring outside the hospital, like a major hemorrhage or eclampsia at a home birth or a peripheral clinic, to provide immediate on-site resuscitation and stabilization before or during safe transport to a higher-level facility.
That really highlights the tension, doesn't it?
It does. It raises that important societal question. How do we best balance the valid desire for personalized, low-intervention, potentially out-of-hospital birth experiences with the undeniable critical need for immediate access to high-level medical intervention when the unpredictable complications of labor inevitably arise for some women? It's a complex balance with no easy answers.
Absolutely. And beyond the clinical science and the logistics of where birth happens, what about the human element, the emotional, psychological side of labor? That must be hugely significant too.
Oh, it's paramount. We can't discuss labor management without acknowledging this. The sources emphasize that labor events have profound psychological, emotional, and social impacts on the woman and her entire family. She's undergoing intense physical sensations, often significant pain, coupled with the stress of the unknown, and frequently fear or anxiety. Therefore, the caregivers, the doctors, midwives, nurses must be tactful, sensitive, empathetic, and respectful throughout the entire process. Providing continuous emotional support during labor is strongly recommended. Having a chosen companion, present a partner, family member, friend, or doula, has been shown in studies to not only improve the woman's experience, but also to potentially reduce her need for pharmacological pain relief and even decrease the likelihood of operative delivery, like forceps, vacuum, or C-section. Maintaining the woman's privacy and dignity is essential. She should be kept informed about what's happening and involved in decisions as much as possible. The overall goal, as stated in one source, is to create an environment characterized by skill and confidence from the caregiver, combined with appropriate support, so that a woman feels empowered and able to give birth with dignity.
That's so important to remember.
It really is. And it's fascinating, isn't it, how even something as seemingly soft as continuous emotional support can demonstrably impact physiological outcomes, like the need for medical intervention. It just powerfully underscores the deep, inseparable mind-body connection that's at play during the profound experience of childbirth. Hashtag outro. So we've really journeyed through the incredible depths of human labor today, haven't we? From its still somewhat mysterious chemical beginnings and the precise choreography happening inside the cells, all the way to the dynamic reshaping of the body's anatomy, the uterus transforming, the birth canal forming, and that intricate adaptive dance the baby performs to finally be born.
It's a truly awe-inspiring process when you break it down like this, a real testament to the biological genius encoded within us. Hopefully, for you listening, you now have a much more profound understanding of the what, the how, and the why behind one of life's most fundamental experiences.
Yeah, just to recap some key takeaways. We learned that normal labor, or eutosha, has those 5 strict criteria: spontaneous onset at term, head first, no undue delay, minimal aids, and no complications. Anything else falls under dystocia or abnormal labor. The actual onset trigger remains, well, largely obscure, but the leading ideas point to a complex mix. Uterine stretching, crucial signals coming from the baby and placenta, and that intricate hormonal dance, especially the changing estrogen-progesterone ratio, paving the way for prostaglandins to really kick things off at the cellular level, mobilizing calcium for those muscle contractions.
Right, and we unpack those important preliminary signs, helping distinguish false pain from the true signals of labor starting, like the show or the bag of four waters. And then, of course, the three stages of transformation. The first, the long cervical stage, all about preparing the passage. The second stage, the active fetal expulsion driven by contractions and pushing. And the crucial third stage, delivering the placenta, relying on the body's ingenious living ligature mechanism to control bleeding.
And we absolutely can't forget the baby's incredible journey, that series of cardinal movements. Engagement, descent, flexion, the vital internal rotation, crowning, extension as the head is born, restitution as the neck untwists, and finally external rotation aligning with the shoulders for the final exit. It's a true dance of adaptation, and we saw how clinical management overlays this natural process, from meticulous monitoring using tools like the partograph to carefully guiding the delivery, providing support, and especially the importance of active management of the third stage to minimize hemorrhage risk, constantly balancing natural processes with necessary scientific interventions.
It covers so much ground. So as you reflect on this deep dive, maybe consider this provocative thought we were discussing. Given the extraordinary precision and coordination required for a normal, uneventful labor, and acknowledging the numerous points where deviations can occur, what does this complexity tell you about the inherent resilience and adaptability of the human body? And perhaps, what does it suggest about the incredible evolutionary pressures over millennia that must have shaped this fundamental yet still somewhat perilous process?
Yeah, think about how many seemingly small details, from the exact balance of a specific hormone to the precise angle of a baby's head entering the pelvis, how they all have to coalesce perfectly for this monumental event to unfold smoothly. Understanding the intricate mechanics of birth, I think, can only foster a deeper respect and awe for every single individual's journey into the world.
It certainly gives you a new appreciation for every birth story, doesn't it? Keep asking questions, keep exploring the wonders of the body, and keep diving deep with us next time.